Good afternoon to everybody. It's my pleasure to be here today with you in this webinar of the European Society of Gynecology. Today, we will have a fantastic and very important topic in clinical practice, which are myomas and their concepts. And we have two speakers. One is Professor Michel Nisolle from Belgium, and the other Professor Natalia Pedachenko from Ukraine. Everybody knows them, but just to remind you, Professor Michel Nisolle is president of the Obstetric and Gynecology Department at University of Liège in Belgium and head of University GynObst Department at University of Liège in Belgium too. Her clinical activity is focused on endoscopic management of benign pathology, especially endometriosis, Mullerian malformation, and fibroids. And this is the reason why we have invited her to participate to that talk. And she is particularly involved in endoscopic surgery teaching in the complementary gynecology and obstetrics master. She created a university endometriosis care center called LUCERM and is to provide comprehensive and multidisciplinary patient care. This is very active in scientific society, such as European Society for Gynecological Endoscopy, ESHRE, European Society of Gynecology, French Foundation for Research on Endometriosis, and journals such as Fertility and Sterility, Facts, View and Vision in Obgyn, European Gynecology and Obstetrics, and invited speaker in international congress and author of numerous book chapters and publications in renowned journals. And research focused on endometriosis, adenomyosis, ovarian representation, and myomas. And it's my pleasure now to ask Michel Nisolle to start their presentation. I will present Professor Natalia Pedachenko at the end of Michel Nisolle's presentation. And I remind to all of you that you want to put question, I will read the question. You have to write your question in the question and answer area, and then I will read for you at the end of both presentations. Please, Michel, you have your microphone.
Thank you so much, Andrea. It's a real pleasure to be here today to speak with you and to share with you the new insights of physiopathology of abnormal uterine bleeding. So I would like to congratulate Professor Ganazzani for organizing so very interesting webinar, which represents the life of the society.
Thank you.
So I have no conflict of interest. About the definition of heavy menstrual bleeding, in fact, you can see that it's excessive menstrual blood loss, which interferes with the woman's physical, emotional, social, and material quality of life, and which can occur alone or in combination with other symptoms. Concerning the definition of abnormal bleeding, you can see in the literature that usually we can speak about prolonged duration of flow, more than 8 days, and also heavy monthly blood loss, more than 80 milliliters. Concerning the objectivation of the heavy menstrual bleeding, you have the pictorial blood assessment chart, and it means that you can ask to the patient when you are conducting some clinical trial in menstruation and abnormal uterine bleeding, you can ask to the patient to have a number of points, meaning that at the end of the menstruation you can calculate the pBAC, and if the pBAC is more than 100, it means that the patient has abnormal uterine bleeding. Concerning the epidemiology of abnormal bleeding, in fact, you can see here an old epidemiological survey conducted in UK. And in fact, if you look at that time, we were speaking about menorrhagia, but today I will explain to you that nowadays we are not speaking about menorrhagia, but the problem of abnormal uterine bleeding is occurring in 25% of women. So it's very important. So the main point of today is to remind you the physiology of the endometrium and the regulation of menstruation. And as you know, you know that very well, but when there is a withdrawal of progesterone, in fact, this is the trigger of menstruation. Of course, if the patient is pregnant, there is no menstruation. And in fact, this progesterone decrease will provoke an influx of innate immune cells. And here you can recognize the menstrual phase endometrium, and you can see that there is an influx of different type of cells, macrophage, neutrophil, and also uterine natural killer cells. The decrease of progesterone will also increase the expression of inflammatory mediators, including prostaglandins, and also increase vessel permeability and tissue breakdown. And in fact, this inflammatory event manifests as menstrual bleeding. This slide is very important because in the physiological situation, and you can recognize the different phase of the cycle. So it means when the physiological situation is recognized, it means that the patient will have a blood loss of more or less of 40 milliliters of contain, and certainly less than 80 milliliters. And in fact, the different phases that we can see is that the progesterone withdrawal will provoke a contraction of spiral arteriole. You can recognize here the spiral arteriole. In fact, this is due to an increase of vasoactive factors, endothelin and prostaglandin F2 alpha. And in fact, this vasoconstriction, the contraction of the spiral arteriole are very important because this is the reason why there is a limitation of menstrual loss. And in fact, here you can see the vessels. You can see that the vessels are mature, and due to the effect of vasoactive factors, the diameter of the vessel will decrease, and it will explain why the patient has a normal blood loss. And you can see also that during that moment, the local endometrial environment is exposed to inflammation, hypoxia, and thereafter repair. So to remind the physiology is very important for the next slides. And in fact, according to the papers of Hilary Kitchley, and in fact, she works a lot on that topic, the menstruation is a balance between different steps: proliferation, decidualization, inflammation, hypoxia, apoptosis, hemostasis, vasoconstriction, and repair. And in fact, if you have an imbalance in any one of these processes, you have abnormal uterine bleeding. And in fact, it could be in duration, frequency, regularity, and volume. And in fact, nowadays, we cannot speak about menorrhagia, oligomenorrhea, and metrorrhagia because those terms are out of date and should be abandoned. So we have to speak about abnormal uterine bleeding only. So you know very well the classification of the cause of abnormal bleeding, published by Munro on fertility sterility a long time ago, and you know very well the palm coin classification, explaining the different causes of abnormal uterine bleeding. And today we will speak, of course, only about leiomyoma. And you can see that it could happen in more than 80% of all women by age of 50 years. And of course, the myoma are usually benign. So we can say that to explain the abnormal uterine bleeding by the fibroids, the relationship between abnormal uterine bleeding and fibroids remain incompletely understood. And there is a paradox because many women have fibroids, but also have entirely normal bleeding patterns. And finally, fibroids are also highly prevalent in women presenting with abnormal uterine bleeding. So I would like to speak with you about 2 points. The first one is which myoma will cause abnormal uterine bleeding. And the second part is the pathogenesis of abnormal uterine bleeding. Concerning the FIGO classification of the myoma, you know that very well, this FIGO classification, and usually we are speaking about the FIGO 0, 1, and 2, and 2 when you are speaking about myoma, submucosal myoma. You know that by transvaginal sonography, there is no difficulty to diagnose those myoma. But in fact, this is a second publication of the FIGO of Munro. And in fact, the leioma category is subdivided into two things: the myoma with impact on the endometrial cavity, and on the other hand, the myoma without impact on the endometrial cavity. And in fact, this second publication is conducting that finally we could include the myoma of type 3 as submucosal myoma. And in fact, if you look at the type 3 myoma, usually there is no deformation of the cavity, but this myoma is touching the endometrial cavity. So nowadays, when we have a submucosal myoma, we have the type 0 to 3. It means that the abnormal uterine bleeding is associated with a leiomyoma submucosal. And when there is no local distortion of the cavity, it means that we are with the myoma of class 4 and higher, 5, 6, and 7, and so on. So concerning the classification by transvaginal sonography, there is no difficulties. By magnetic resonance imaging, in fact, it's very important for us because we can imagine that this myoma and certainly this one are responsible for a distortion of the uterine cavity. And of course, we have an exact localization and impact on the uterine cavity. On the other hand, those myoma are not related to the endometrial cavity and probably are not responsible, in fact, on the abnormal uterine bleeding. So to perform the diagnosis, we have also the office hysteroscopy, and here you can see the different type of myoma that we can see. And in fact, the main point of today is that with regard to the location of fibroids, it was previously, because nowadays we have to change, it was previously thought that those women with submucosal fibroid, particularly with those distorting the cavity, were more likely to present with abnormal uterine bleeding. So it means that there is certainly a place for the surgical management. I will go very quickly through the surgical management because it's not my topic, but here you can see the hysteroscopic view of a small myoma, and it's not difficult to remove. Here you can recognize class 2 myoma, but the major part is located into the myometrium. And here again, you have another myoma just in front on the anterior part of the uterus. So this is not too difficult. Of course, we have also in this patient a large myoma, and we could imagine that this myoma is responsible for abnormal uterine bleeding, and there is no difficulty to perform the laparoscopic myomectomy by using the classical step of surgery. Of course, we have many tricks and tips to avoid complication. And also nowadays, we can also use the robotic-assisted laparoscopic myomectomy. And here in this case, you can see a very large myoma, probably responsible for pelvic pain or for abnormal uterine bleeding. So there is no limitation to perform the endoscopic surgery for those patients. So after that, of course, we have to close the myometrium. So now I think it's very important to share with you the pathogenesis of abnormal uterine bleeding in relation with myoma. In fact, we know until now that there is, if there is an increase in the endometrial surface, there is a risk of an abnormal uterine bleeding. Again, an increase in uterine vascularization is responsible of abnormal uterine bleeding. The change in patterns of myometrial contractility due to the presence of a myoma into the myometrium. A myoma degeneration could also be an explanation, and also the compression of the uterine venous ectasia compressed by the myoma. And also, as we already discussed, the degree of distortion of the uterine cavity. So what is new nowadays? In fact, what is new is this. In fact, there are more and more researchers analyzing the complex cellular and molecular changes found in association with fibroids with impact on angiogenesis, alteration in vasoactive substrates, growth factors, and also alteration in coagulation. And in fact, the most important thing of today is that the effect of fibroids on endometrial function is not limited to the region overlying the myoma, but also within the uterine cavity. And this is very important for myoma, of course, of type 3, because it could have an impact on endometrial receptivity and implantation, as well as in patients with abnormal uterine bleeding. So in the past, we believed that only the endometrium covering the myoma is abnormal, but nowadays we think that all the endometrium is also altered. So concerning this analysis, and in fact, it's the work of Hilary Critchley and the different cellular and molecular changes that she observed, was donc with an impact on angiogenesis, alteration in vasoactive substrates and growth factors, and alteration in coagulation. And again, I am coming with the previous slides. On the right, you can see the physiological situation and what happens in pathological situation. In fact, you directly see the difference between the diameter of the spiral arteriole. And in fact, in cases of pathological menstruation, you have enlarged arteriole. It means that there is a decreased spiral arteriole maturity. It means that those vessels are immature. There is also a reduction in vasoconstrictive factors. There is a decrease in endothelin. So it means that the patient with large vessels, with a reduction in vasoconstriction, will have heavy bleeding. So it means that the patient will have an increased blood loss, more or less 100 milliliters. And you have also the inflammation, but no hypoxia, and also the repair. So you will see the difference between the pathological situation and the physiological situation. So this could explain, of course, that the vessels are larger and explaining the amount of blood loss. So what are the role of the vasoactive substance, vasoconstrictive substance in abnormal uterine bleeding? In fact, we already spoke about endothelin 1. This is a vasoconstrictor that affects spiral arterioles and plays an important role in myometrial contractility. There is altered expression levels of endothelin 1 and endothelin receptor in uterine fibroids that may interfere with the normal physiological function of the myometrium during menstruation. And the vascular function of the adjacent endometrium is also altered, giving rise to its irregular development or shedding. So there is also a different composition of inflammatory cells, which is different in areas of the endometrium that overlay fibroids compared to with distant sites. And in fact, in the perifibroids endometrium, there is an increased number of macrophages in all phases of menstrual cycle. You remember at the beginning, I showed you that there was an increased influx of macrophage only during the menstruation. There is also a decreased number of natural killer cells in the secretory phase. And in fact, there is also increased level of prostaglandin F2 alpha in uterine fibroids, which may explain the distorted contractility and increased blood loss. So what about the growth factors? In fact, we know that there are also increased levels of the basic fibroblast growth factor in fibroids. The increased expression of the beta fibroid growth factor receptor in endometrium associated with fibroids. There is a possible pathophysiological mechanism underlying increased angiogenesis in fibroids and abnormal uterine bleeding. And also, again, the paracrine interaction between fibroids and endometrium is not just localized to the endometrium overlying the fibroids. The global effect is on the endometrial function. And in fact, we know that there is an increase in the transforming growth factor beta 3 in cases of myoma. And this is an older publication you can see in 2011. And in fact, the TGF-beta3 is produced by uterine leiomyoma and regulates the cell proliferation, angiogenesis, apoptosis, and migration. And here you can see the normal myometrium when compared here with the myoma with an increase of the transforming growth factor beta-3. And in fact, the role of this transforming growth factor in the myoma, in fact, that there is a direct impact of transforming growth factor beta-3 on factors that impair local endometrial hemostasis. In fact, if you look the endometrial stromal cells, the TGF-beta3 reduce the expression of PI1 and thrombomodulin. In fact, here you can see the control and here the leiomyomata. And if you analyze by immunochemistry the PI1 and thrombomodulin, you will see that in cases of leiomyoma, there is a decrease of those expression, and it means that there is a reduction of hemostatic factors in the endometrial stromal cells. A very interesting paper is a colleague of Hilary Critchley. And in fact, you can see on this slide that the endometrial disorder that we can see if the patient has some myoma, on the left side, we can say probably that there is a primary endometrial disorder not in relation to the presence of myoma. But nowadays, there are more research about the secondary endometrial disorder. It means that possibly the myoma located in the myometrium is responsible of the endometrial disorder. It means a decrease of hypoxia, an increase of inflammation, decrease of hemostasis, and a decrease of vasoconstriction, which could explain the abnormal uterine bleeding. But this is under research. So concerning the different physiopathology of the abnormal uterine bleeding in cases of myoma, we can say that there is a problem with the myometrial contractility. There are certainly paracrine signaling, the growth factor, the prostaglandins, endothelin, and angiogenic factors, and also a problem of hemostatic regulation. In fact, there is an alteration in the expression of clotting factors. And in fact, to conclude, I think that, of course, we can still operate the patient with myoma, but in fact, probably to avoid the abnormal uterine bleeding in relation with myoma, explained by the abnormal endometrial development, we have to develop new therapeutics for women with fibroids in order to treat them correctly. I thank you for your attention.
I thank you. Thank you very much, Michelle. And we will have receive questions. I suggest everybody to write their question in question and answer, and then we read that for you. And now we will go to Professor Natalia Pedachenko. Just to remind you, Natalia Pedachenko is head of the Obstetrics, Gynecology and Perinatology Department in Shupik National Healthcare University at the Department of Obstetrics, Kyiv, in Ukraine. The predominant areas of professional interest is endocrine gynecology, namely management of women with various disorders of the menstrual cycle, abnormal uterine bleeding, endometriosis, polycystic ovary syndrome, metabolic syndrome, premenstrual syndrome, uterine leiomyoma, and also menopausal disorder. She's do also very important activity in endoscopic gynecological surgery, hysteroscopy, laparoscopy, management of cervical pathology by colposcopy, and treatment of ambulatory endocrine infertility. She's member of the working group of the Ministry of Health of Ukraine for the development of national clinical gynecological guidelines, and she's executive secretary of the Society of Gynecologists and Endocrinologists of Ukraine, and coordinator of the educational branch of the Association of Colposcopy and Cervical Pathology. Natalia, you have the microphone. Thank you for sharing your slides. And I remind all of you that we will have the general discussion with Professor Michel Nisolle and Professor Natalia Pedachenko at the end of Natalia Pedachenko presentation. Thank you. You can go on.
Well, dear Professor Andrea Genazzani, dear Professor Michel Nisolle, for me it is really a great honor and pleasure today to speak in such an honored company, and the topic you, Andrea, had chosen is really outstanding and absolutely nowadays important. So thank you for your kind words for my presentation. And now I would like to speak a little bit, following 25 minutes, about the challenges in fertility sparing management of uterine fibroids. My speech is about a very big teamwork of our Ukrainian Medical Gynecological Society. The head of this team is Tatiana Tatarchuk. Natalia had a big PhD and other scientific works concerning this very important topic. And Katerina Plaksiva, one of the PhD researchers, made a great job. And now I am presenting this big achievement of our team working. A little bit about a plan of our topic, and of course the most important is at the end about the reproductive results of uterine fibroid treatment in our faculty, in our personal we will share with you our personal experience. What is the best methods? Of course, the risk factors for women with fibroids are, first of all, age, unfortunately, then the race. African Americans have more frequent percentage of this disease. Obesity is really evidence-based great reason for developing of uterine fibroids. Family history, high blood pressure, no history of pregnancy, vitamin D deficiency, food additive consumptions, and interestingly, use of soybean milk. Of course, talking about evaluation, how we evaluate our patients, of course, we take history, a family history, personal history, reproductive history, we make ultrasound, 2D or 3D. It depends on the case. If 3D is needed, okay, let's do it. Saline infusion sonogram if it is necessary, hysterosalpingogram when we try to understand how the tubes, fallopian tubes work, office hysteroscopy, MRI, CT. So our list of examination is here, and talking about the history, it is very interesting paper by Vilas et al. That very emerging hypothesis of the epidemiology and about the pathogenetics for human beings, how the uterine fibroids had developed, that it can be a consequence of obstetric dilemma and the evolution of bipedalism in our hominin centers when we started to be B-pendant, when we were before some theories say that a human being was pedental, and now we have only 2 legs, and the uterus has to become more strong with more muscles, making it more forceful for delivering a baby. And so after it appeared, it became a great base for future formation of uterine fibroids. Very interesting paper, and I would be really happy if you will find it in Human Reproduction and make a joy. It's very fresh paper, 2024, reading it. So the symptoms, of course, always are the result of fibroid site and the location of uterine fibroids. Of course, clinical symptoms are bleedings, pelvic pressure or pain, frequent urination, constipation, difficulty emptying the bladder, of course, and difficulties emptying the gut, back pain, leg pains, dyspareunia, and of course infertility. So there are also published recently very interesting 7 hypotheses. How does the mechanism of infertility work? when women have uterine fibroids, and in parallel they have infertility. First of all, first reason for the infertility is, of course, the sexual dysfunction. When a woman has longitudinal pelvic pain, dyspareunia, and prolonged heavy menstrual bleedings, of course, it interferes with sexual arousal, and of course, it makes a consequence for frequency of intercourses. The other reason is disturbed oocyte and sperm transport. Of course, uterine fibroids located in the special places can make physical compression of the intestinal part of the fallopian tube and make also the deformation of uterine cavity. Then, disturbed peristaltics of the junctional zone of the myometrium can make the problems with implantation. Then changing in uterine vaginal microbiome also makes the possibility for inflammation to develop. Disturbed levels of inflammation in autophagy, and Professor Nisolle showed very nice pathogenetic mechanism of this process, inflammatory process, molecular changes in the endometrial, and of course the aberration of angiogenesis and altered endometrial blood supply, which was brilliantly shown in the previous lecture. All these things make problems achieving a healthy baby for a family. I would like to share you now very interesting information that in 2023, during the war in our country, our department, under the auspices of the Ukrainian Society for Gynecologists and Endocrinologists, were directly engaged in the development of the evidence-based guideline and healthcare standard of care uterine leiomyoma, which is obligatory in our country. Of course, our guideline is fully based on the principles of evidence-based medicine, taking into account the current international recommendations reflected in the following guidelines, as you see here: Society of Obstetricians and Gynecologists of Canada, a Practice Committee of American Society for Reproductive Medicine, and NICE guidelines. And all these guidelines were adopted for our Ukrainian clinical and financial healthcare situation. And it is very interesting and nice document, which is always absolutely free for downloading from the website of the Ministry of Health of Ukraine. And what is the main idea for fertility preserving treatment in women who would like to preserve uterus and deliver a baby later? So, managing patients with uterine fibroids, first of all, depends on the desire to preserve fertility. If a patient desires and has abnormal bleedings and pain, we always start with pharmacotherapy. Never propose surgery for the patient first. Tranexamic acid, NSAIDs, oral contraceptives, not for uterine fibroid treatments, but for example, for bleeding treatment, for abnormal uterine bleeding treatment, for example. It can be also progestogens, including levonorgestrel intrauterine device, GnRH agonists, and others treatment. If it doesn't work, then, or symptoms persist, or it is a stage, first step for the surgical treatment, then we can perform myomectomy laparotomically or endoscopically. Also, it is very common to use the other invasive methods, but less invasive than surgery methods for treatment, is uterine artery embolization, UAE, and focused ultrasound. And of course, you see, there are a lot of connections between these boxes, because each type of treatment can be followed by other or from the beginning made a combination of it when, for example, we have multiple fibroids or we have really huge sized fibroids, and we want to preserve uterus for future reproductive good outcomes. And here we can see the result of work of our clinical team from 2002 till 2021. It is a very interesting retrospective survey of 744 women of reproductive age, and we can see here that there were some different treatment methods: combined treatment, conservative myomectomy, laparoscopically or laparotomically, uterine artery embolization, and use of ulipristal acetate. And you can see that the result of treatment was very interesting, and you can see the age distribution here in these graphics. Mostly young women were more likely to use ulipristal acetate, and elder women were more frequent to use uterine artery embolization during this follow-up period. Very interesting slide also. It is very important, very, very important to understand that a lot of women changed their original plans and decided that they want to get pregnant only after treatment. So it is very important for us clinical doctors, when asking a woman, do you want to have a baby or you would like to remove your uterus? Maybe she will say, I don't want children. But if you start with conservative management, with medical management, and try to save the uterus, a lot of women can change their reproductive plans. And you here see the statistics, and it is really very impressive. And it appeared out very impressive for us also. As you can see here, the reproductive outcomes after the treatment, it is very important to notice that the best reproductive outcomes for any age were achieved by therapy with ulipristal acetates. You see 63% of pregnancies and 56% of live births. And then combined treatment showed good results for reproductive outcomes, 32% of pregnancies and 41% for live births. And of course, as it was expected, the high rates of pregnancies and births were achieved during all methods in women of younger reproductive age subgroups. Let's go on further. In women of younger reproductive age, myomectomy demonstrated the greatest effectiveness in terms of fertility. You see that after myomectomy in younger age, 78% of pregnancies and 78.9% of live births. But for women with advanced reproductive age, the ulipristal acetate demonstrated the greatest effectiveness. 65.2 pregnancies and 44.9 live births were achieved in the advanced age group. Well, what about the recurrence? It is also very important to understand that different methods have different results and different recurrence percentage. For example, the lowest rate of recurrence, 5 to 15 years interval after treatment, was noted in women who underwent uterine artery embolization as a monomethod. So it is more effective for preventing the recurrence of fibroids. In patients with ulipristal acetate treatment, the recurrence was around 18%, and however, the highest recurrence rate was observed after the combined treatment. For example, for conservative myomectomy, 36%. Talking about the method of uterine artery embolization, it is not the method of choice for women who desire to preserve fertility, but sometimes there are clinical situations when you cannot use anything else. For example, we had a situation of 25 fibroids. How can you cut them off? It's really impossible. But what is very important, that the pre-operative examination has to be performed properly, and of course the oncological pathology of endometrium has to be firstly excluded. We have to inform the patient about the characteristics of post-embolization period previously. Modern angiography, it is a very important point because the reduced radiation exposure, high resolution and clear visualization of anastomosis and anomalies can prevent off-target embolization. For example, ovary, which is also one of the reasons for low reproductive outcomes, because this emboli can reach ovarian arteries. The calibrated bicompatible emboli, it is a very good solution because in good angiographs, we can select the type, and here you see syringes on the top with different colors, the type and size of embolis, depending on the vessel diameter we can see on this modern angiograph, for example. And we have the possibility to introduce the antibiotic before embolization, intraarterially antibiotic, because after you make an embolization, the antibiotic will not reach inside the fibroid and it will go on with a high level of inflammation. And post-operative anesthesia, antibiotic therapy, and observation has to be done perfectly. And as you see here on this slide, the uterine volume and fibroid volume regresses really impressively. And we have very small average exposure time and the dose of the exposure. It's very good situation for women who would like to preserve fertility also. So how does the new uterine arteries embolization technique influence the post-operative period? There was another survey of not retrospective, but prospective survey for 40 patients who underwent new modern angiography and uterine arteries embolization. And the goal was to evaluate the quality of life, the post-operative period, as well as the duration of hospitalization, the pain according to the international scale, and duration of disability. And here you can see also really impressive and important results, that using new pre-operative technique, using new intraoperative technique, modern embolis, modern angiography, you can make really very good results with post-embolization syndrome and duration of pain and hospitalization and work and disability also. It can be reduced even threefold times in comparison with the traditional method. So what are the main issues that can help us to make the best results treating women who would like to preserve their fertility, treating uterine fibroids? For conservative operative surgery, yes, for conservative myomectomy. Well, this operation does not affect fertility, but of course, as we had seen, it has 36.4 recurrence rate after the treatment in the range of till 15 years after surgery. So we have to make something to make the recurrence rate a little bit lower. For uterine arteries embolization of all methods, it has the lowest percentage of recurrence, but there is a risk of declining fertility. So we have developed and published it also some preventive measures, and we have developed them and used them, and they really work nicely. And I would be happy to share them with you. Well, we have to make a pathogenetic impact of all modifiable risk factors for fibroids. We have started our talk today with the risk factors, and now we can try to modify it. For example, correction of body weight, and of course, to lower the insulin resistance and the level of insulin, which is very proliferative hormone, proliferating stimulation hormone. correction of vitamin D levels, correction of hyperprolactinemia, and it is very important. Then we have found a very high percentage of hyperprolactinemia in patients with uterine fibroids, but it is a stressed hyperprolactinemia, about 40-50 nanograms per milliliter. So it can be corrected with, for example, agnus castus administration, and does not need some other chemical, let's say, agents. Then correction of physical activity parameters, daily diet in accordance with the initial parameters of body weight. How else can we help? After for uterine embolization and also for conservative myomectomy in post-operative period. We can help and restore the microcirculation of the ovarian tissue. Rectally, transrectally, we administrate usually the suppository with streptokinase and streptodornase for the purpose of lysis of microthrombi in small vessels, restoration of adequate microcirculation. It has huge anti-inflammatory effect, and of course, it enhances it is proved to enhance the penetration of antibiotics into the inflammatory focus after the surgery or after the embolization procedure. So to talk about the generalization and to summarize, I think that the main idea that we have to provide the organ fertility preserving treatment in all possible cases, because women can change their plans after the treatment, after some period of life. And of course, I understand that all the doctors who are together with us now are type of doctors that love women, want to stimulate them for childbearing, and we are a team also. Thank you, everybody, for your kind attention.
Thank you very much, Natalia, for the beautiful presentation. And now I also want to invite Professor Nisolle, and we will start with the general discussion. I have already received some questions. And Michelle, we have received one for you. And that is, as we know that myomas of type 3 could also involve adverse uterine bleeding, how to perform the management of such myoma, surgically or medically?
Okay, so this is a very important question, because for surgeon, the type 3 myoma is the most difficult type to treat, because it's a small one. Type 3, it means that it's less than 3 centimeters or 3 centimeters maximum, but touching the endometrial cavity. So in fact, to treat by hysteroscopy, it's possible, but nevertheless, it's difficult because we have to localize exactly where is the myoma. And maybe the future should be the medical treatment. If we obtain a good decrease in size of the myoma, it means that probably the myoma will be not attached to the endometrium, but if the myoma is smaller, becoming 1 centimeter from 3, it means that maybe the operation could be avoided. But to decrease the myoma size, until now, we have agonists of GnRH analog or antagonists. This is the only medication that we can use. I will certainly not recommend the embolization.
Thank you. Thank you. And then now we have received one question from an anonymous spectator. I think, Natalia, for you. What do you think about transvaginal radiofrequency ablation or microwave ablation regarding type 3 myomas? If you or Michelle, do you have any experience about that one? Please give your answer.
And dear Andrea, personally, we don't perform this ablation, and it is very difficult to find the place of type 3 myoma during the hysteroscopy. So maybe talking about this type of fibroid, it is really important to understand the reproductive plans and to avoid surgical operation, of course. In women who would like to preserve fertility, of course, the method of uterine arteries embolization is not a method of choice, as we have seen in my presentation. But if we don't have any other suggestions, focused ultrasound can be performed also, but it doesn't help to take off the myoma. It just helps the uterine fibroid not to grow.
Yes.
And maybe gonadotropin releasing hormone analogs for some period of time.
Yes, I think also this is another part very important. And then we have now Shiviraj ask, Michelle, how to treat a female who desires fertility with multiple fibroids that are submucous and intramural approach, where myomectomy for all is not possible?
Usually when you have a multiple submucosal myoma, first I think that we have to try to decrease the size, but nevertheless we have to try also to remove them. But sometimes it's needed to perform several hysteroscopic myomectomy to avoid adhesion, because as I showed, but very quickly in my video, if you have a myoma on the anterior part and another one on the posterior part, if you remove them at the same time, you have a risk of adhesions. So it's better to try to treat the patient in different hysteroscopic surgery.
Thank you very much. And then, Natalia, you already mentioned in your last answer, but it's a question. Do you prescribe combined hormonal contraceptive for fibroids treatment?
Oh, very good question. Thank you, dear colleagues. Thank you, Andrea, for addressing it to me. We don't treat uterine fibroids with hormonal contraceptives, but if a woman has a complaint for abnormal uterine bleeding and she needs a contraception, and her size and location of uterine fibroids permits this administration, why not? She can be prescribed combined oral contraceptives for contraception and bleeding management, for example. That's it. So it can be prescribed, it is not forbidden, but not for fibroid treatment, of course.
Thank you very much. And then, Michelle, for you, still on myomas of type 3, is the approach of this type of myoma similar in infertile patients and in patients with adverse uterine bleeding? Michelle?
This is an excellent question, Andrea, and thank you for asking that question. In fact, we have to distinguish the symptoms of the patient. I have no difficulties or no problem to propose an hysteroscopic surgery in those patients, but I would recommend firstly the medical treatment in patients with desire for pregnancy to avoid the endometrial removal during the surgery. But if the patient is older and with a type 3 myoma responsible of abnormal uterine bleeding, I will remove it, and I will also remove all the endometrial tissue, in fact. So it's easier in patients with abnormal uterine bleeding without any desire for pregnancy.
Thank you. And then now, Shiviraj asked, I think this is for Natalia, because you mentioned this treatment. How safe is to use ulipristal? Because it's FDA approved for myomas, because this is something that we have to answer.
Yeah, it's a very good question, and I was, to tell the truth, expecting it. Now it is indicated to use ulipristal acetate only for pre-operation period to prepare the patient for the further conservative myomectomy, independently of the type of the surgery, laparoscopic or laparotomic access using.
Yes.
It is safe. It is not forbidden to use it, but not for fibroid treatment.
It's not forbidden in Ukraine.
Yes.
In most of the countries, for example, in Italy, we have it's no more available for that one. We can have ulipristal only for emergency contraception, but not for the, unfortunately, because we were very happy with it.
Yes, it works perfectly. But after some HEPAR transplantations, it had problems. Then it appeared again, and then it disappeared again. But now it is allowed only for preparation of the patient before the surgery.
And then we have, Michelle, we have a question from Alice Philippot, who made the congratulations for the webinar. And the question, what drug do you propose for fibromatosis due to estrogenic cause versus progesterone cause? I think it's quite difficult to distinguish if a myoma can have only progesterone causes or only estrogen. But do you have an answer for that?
Okay, it's medical treatment, you mean?
Yes.
So, of course, in the past, we believed that myoma were only estrogen-dependent disease. Nowadays, we know that progestin is also responsible of the growth of the myoma. This is the reason we developed the ilicrystal acetate. So nowadays, I don't know if you have the possibility, but here in Belgium, we have the possibility to use the oral antagonists of GnRH associated with the add-back therapy. So in my department, we prefer to use that new medication instead of continuous progestin due to the meningioma problems and so on. So I would recommend the new therapeutic, it means antagonist with add-back treatment.
Yes, which is now under very well developing also here in Italy. And then we have a question for Natalia, for you. For intramural myome, what is the cutoff on size for myomectomy for a woman who desires pregnancy? Also,
tell the truth, I don't know the cutoff for conservative myomectomy because we had 30-week gestation size myomas during all the years of follow-up. And the situation is how to prepare the patient for this conservative myomectomy. Maybe she has to use medical treatment to smaller the size, to smaller the vessels, to make the operation possible. But I even had shown some pictures with very huge myomas, which were performed laparotomically, of course, myomectomy.
thank you, Michelle, because it's a very practical question. What is your believing about the size, possible size of for the intramural myomectomy in women who desire pregnancy? What is your, what are you doing?
Yes, so if there is a large myoma, intramural myoma of type 4, 5, and so on, I think that there is no limit. The limit is the way to perform the surgery. If you are a good surgeon and if you are using the robotic surgery, I show you a short video in my team. They are operating, not myself, but my team is operating myoma of 10 centimeters without any problem. The problem is when the myoma are multiple, sometimes it's more difficult, but there is no limit in size, in fact.
Absolutely, I agree with you. And Natalia, we have a question from Chibuike Chingbu. Please, I would like to have more information on recurrence rate of myomas in women treated with high frequency focused ultrasound compared with myomectomy. If you have experience on that one, I don't know.
We did not include into our survey actually the this method of treatment of focused ultrasound because actually we don't really believe in its good effectiveness. We have this method in Kiev city and we see patients using this type of treatment. Let's say it's very expensive. It is rather painful and it has very high recurrence rate.
And
So,
Michelle, do you have any opinion about that point?
Yes, in fact, the recurrence rate for me is not so important in patients with desire for pregnancy because if you perform the surgery, the main goal is to obtain the pregnancy. If the patient has a recurrence 5 years or 10 years after the pregnancy, of course she can be operated again. But for me, there is no concern about the choice of treatment with the risk of recurrence. The main goal is to obtain the pregnancy, and after we will see.
Thank you. And also another question, Natalia, from Valiluyah Oni. Please, how do you prescribe treatment for myomas coexisting with endometriosis? And I would like also to add coexisting with adenomyosis.
Very good clinical question. Of course, it really oftenly coexists. And We can use different methods. For example, last week we made a conservative myomectomy for a girl who had two types of fibroids, let's say, visible on ultrasound. One of them was a proper real uterine fibroid, and other one was a node form or local form of adenomyosis, and it can be really combined. For example, you go for hysteroscopy and you think that this big plus tissue is uterine fibroid. It is very hard and it looks like, but you receive the biopsy and it is reaching the local form of adenomyosis, and it is rather difficult to distinguish between them, but it goes very nicely and in pre-operative period and just for following up using Dienogest, the same preparation for endometriosis treatment if a woman needs this treatment. And of course, antagonists of gonadotropin releasing hormone, they work brilliantly in this condition, as for endometriosis and the same for uterine fibroids.
Thank you. And Michelle, for you, it's very interesting that one. How we can evaluate the maturity or immaturity of endometrial vessel for adverse uterine bleeding?
Okay, in fact, this is immunochemistry analysis. So you can not see, if you perform an hysteroscopy, you cannot see that the vessels are mature or not. So it means that if you perform immunochemistry, you will see that there is absence of smooth muscle. So you need to analyze precisely the content of the endometrium and to analyze specifically the vessels. But it was done by Hilary Critchley, and it was done also in our department with Professor Fodar. When we analyzed the etiology of abnormal uterine bleeding in patients with hormonal intrauterine device. In fact, it's easy to do.
Thank you. And Natalia, for you, if you want to add something, please go on, Michelle. I'm sorry.
I would like to answer to the previous question. The treatment of patients with concomitant endometriosis and myoma.
Yes.
So for us, we have the new medication oral antagonist with ADBAC, because this medication has the two indications. So you can treat both pathologies with one pill.
No, I think that this new treatment will open a series of new possibilities. And also, this, if we apply that one in the young patient, we have also to see the effect of long treatment on fertility possibilities later on. I would like to have your advice on that point. Yeah, and then now, Natalia, for you, there are questions directly to what you are doing. Which operative technique do you prefer for conservative myomectomy?
Thank you for this question. Of course, it depends on the location of the uterine fibroid. If it is located on the posterior wall of the uterus, it is rather big, and it is located very low. It is rather difficult to perform good laparoscopy with good results and with a short term of the operation time. But of course, mostly we perform laparoscopic myomectomies. But in some cases, when it is difficult to reach the fibroids, of course, we can make a laparotomy also.
Thank you. And Michelle, another question rising from your presentation: is the role of inflammatory molecules in adverse uterine bleeding similar to that observed in infertile patients?
Yes, in fact, in the presentation, I show you that in both, in cases of abnormal uterine bleeding, the influx of immune cells is decreased, and it's exactly the same the same observation that we have in patients with recurrent of implantation in the IVF. So it means that there is a parallelism between both.
Thank you. And then, please.
Yes, concerning the previous question, in fact, if we have a large myoma located very low and posteriorly, in fact, I also do, as you, Professor Pedachenko. But in my team, a young gynecologist and a very active surgeon, they are using the robotic assisted laparoscopy, and they are performing so nice surgery. So I think that's for young people to perform that type of surgery, but it's very effective.
Thank you for this comment. And Natalia, a question to you from Puzang. How long should women wait for getting pregnant after embolization?
Well, we have to wait the short period, 1-2 weeks after the post-embolization syndrome, which can be really made not so acute, not so painful with the modern technique, of course. But after several months, when we see the size of uterine fibroids becoming smaller, when we see good dynamics, okay, let it be. But it is very important to understand that this is not the method for treatment in women trying to achieve pregnancy. But it does not mean that the pregnancy cannot be achieved after the uterine arteries embolization, and we have lots of pregnancy after this technique. The main is to make equalization of the ovaries to protect them from the X-ray, and to choose the emboli exactly, making it the same as the vessels which we see coming to the uterine fibroid. And in this combination, it makes really good results.
Thank you very much. And then, Michelle, you mentioned, this is a question from Pinar Kaglar Aitak. Thanks. The cytological difference in myomas do affect heavy menstruation?
The difference in histology, you mean?
Cytology, the difference in the structure of the myoma and the origin of the cells.
No, I don't think so. I don't think so. I don't know exactly, but I don't think so. But again, Andrea, I would like to make a comment on the previous question. So concerning the delay between embolization and the pregnancy.
Yes, please, you can do.
Yes, okay. So in my department and many departments here in Belgium, embolization is not the first choice of patient with infertility or with myoma, with a desire of pregnancy, because we know that there are complications. But we are in favor of myomectomy, as you can see. But in fact, the delay after the myomectomy is also a question of debate. And in fact, in the past, we considered 1 year, and after we considered 6 months. And nowadays, after 3 months after a myomectomy, we can let the patient to try to be pregnant. But after embolization, I have no idea, because we don't do that, because it's more or less not a good indication for us.
And Michelle, do you believe that embolization can be proposed in perimenopausal time?
Yes, why not? Why not? If without any wish for pregnancy, yes. But I remember a patient with who refused the surgery, and finally she received an embolization, but it was a sarcoma. But it's another story. Huh?
Of course. And then, if you would like to permit me to make another point, I would like to advocate this brilliant method. It is not a method of choice. I fully agree, and I mentioned it hundreds of times. And the other niche for the usage of uterine arteries embolization is, for example, for women with uterine fibroids who start menopausal hormonal therapy, and we see that their fibroids start growing. So it is a very good chance for women who would like to avoid surgical treatment to make this nice embolization, and that's it. They can continue treatment, and these fibroids will disappear in some time, even despite of the menopausal hormonal therapy.
And then I would like now to put a question, because you were mentioning menopause and menopausal hormone therapy. We are strongly supporter of menopausal hormone therapy when this is possible. And in a woman that they have no other contraindication, do you believe that menopausal hormone therapy is stimulating the growth of the myomas, generally speaking?
Is it a question for Professor Michelle?
No, it was you were mentioned. It's for both of you because you know this is a chapter of great importance. You know, also we have because we have the treatment, the treatment with the antagonist and then the adback therapy bring a situation which in fact is similar to what happened in menopause. In menopause, the woman, they don't have any other gonadal function, but they still have the presence of the myoma. And then we suggest that women after menopause, some of them who they want to make menopause hormone therapy. Then is this making any further danger to the woman, or can we choose in the prescription of menopause hormone therapies selective treatment who can provide better results in comparison to the other? The question is for both of you.
So I can begin. So in fact, it would depend on the size of the myoma. Of course, if the myoma is a small one, we will not propose to the patient hysterectomy in all women. So after a few months of treatment, we can analyze the effects according to the symptoms and also, but I think that if there is a growth of the myoma, it will take a long time. So if the patient is without symptoms, we can continue if the myoma is very small. But usually in Belgium, if the myoma is, I would say, 6, 7 and more than that, we will propose first hysterectomy and thereafter the hormonal treatment.
Yeah, thank you. And Natalia, your comment on that point?
I fully agree with this brilliant medical advice, but generally in Kiev, Ukraine, for women desiring to have menopausal hormonal therapy and have big sizes of uterine fibroids, let's say, the first advice will be to make a modern technique of uterine arteries embolization for them and to forget it. Of course, excluding hysteroscopically the malignancy. It is the main idea before uterine arteries embolization for women any age. It is obligatory to have the histological examination of the uterine cavity.
Okay, thank you very much. We are approaching now.
Can I answer?
Yes.
In fact, after the embolization, the patient, as you mentioned, has a post-embolization syndrome. If the patient underwent laparoscopic hysterectomy, the day after she leave the hospital, or the same day, because we can use also the one-day clinic. But after embolization, the pain is more important. Could you precise how many days is during the post-embolization syndrome?
Yeah, it is a very good comment, because previously, when we used the traditional angiographs and traditional methods, it was a terrible post-embolization syndrome. And I was a very young doctor in the beginning of 2000s, and I was the doctor who was taking care of these post-embolization syndromes, and it was terrible. They had fever, they had terrible discharge, they had pains, spasmodic pains, and it was around a week they stayed in the clinic. But now it is 1-2 days. With
Yes.
modern embolies and with modern approach, how we prepare them, we make intra-arterial antibiotic, anti-inflammatory drugs, and then we put emboli, depending choosing the size of emboli depending on the vessel diameter, and it makes the post-embolization syndrome really mild.
Thank you very much, Natalia, for that clarification, because this you answer also to another question from Nirmala Kodaverti, which was asking about the incidence of infection and persistent pain after embolization. But I would like now to go on another question raised by Anonymous. You know that GnRH agonist, the chronic GnRH agonist, was used also as a treatment to induce hypogonadism in women. And then we have a question from this Anonymous: how long the GnRH agonist treatment do you suggest? And is there a limit for period of treatment? Then I would like a comment from both of you on this point concerning not only the efficacy, but concerning also the safety for the women health of the long-term treatment with GnRH agonists in this patient. Please.
Okay. So, in fact, the treatment will not last more than 3 months if there is no add-back therapy, because we know that it's efficacious, but also if you continue the treatment, there is a risk of osteoporosis. And contrary to what happened in postmenopausal women, you cannot recover the quality of the bones after that if you administer calcium and estrogen. So the damage caused to the bones is permanently if you use the analog therapy for more than 3 months.
Yes, this is why we move to the antagonist plus the add-back therapy. Do you want to add something on that one, Natalia?
I fully agree. We had a very nice clinical trial using antagonists of GnRH, and it was brilliant, and it worked perfectly. Now we don't have this at Ukrainian market, unfortunately, due to the war conditions, but we felt this preparation, this drug, and it really is worth coming to our country also.
And we have from Michael Samaha another question for you. Do you recommend uterine artery embolization on rapidly growing myomas? And when do you consider a myoma rapidly growing?
Maybe I can answer to the second part. When do we consider that the myoma is growing rapidly? I would say that during between 2 gynecological examinations. So it means in 1 year, because usually the patients are not going to the gynecologist every 2 months or every 6 months. So if a patient is with a myoma of 4 and 5 centimeters and 1 year later it's 8 and 9 centimeters, for me it's a rapidly growing myoma. But the question is for you, do you will still use the embolization for that type of myoma?
Why not? It will stop the vessels. Why not? We try to measure not only the sizes of myoma, but the volume, because it cannot be grown a lot with the size, but the volume is really extremely greater. I'm not for, I'm I think that the best treatment method chosen by a physician for a person is extremely individual. Sometimes we make only conservative myomectomy. Sometimes we prescribe medical treatment. Sometimes we say, okay, this is the situation for uterine arteries embolization. And it is a very good opportunity to make a choice wider for patients for some atypical myomas. For example, I have already said that we had a patient who wants pregnancy with more than 20. It is very difficult even to count how many fibroids because it's like a bag with potatoes. It was very strange even for more experienced doctors than I am. And what can you do? You cannot cut them off. You cannot prescribe something to disappear, and then you stop it, and she would like to become pregnant, and she will lose her child. So I'm happy that we have this method as a choice for some individual purposes. Let's say something like that.
Okay, then.
Andrea, I would like to make a comment, another one.
Yes.
I think that if you have a quickly growing myoma, we must be careful, because the one unique myoma with growing very quickly, we must be sure that there is no sarcoma. So we have to perform magnetic resonance imaging to be sure, and to discuss with the patient to the risk of letting the myoma instead of removing the myoma and maybe the uterus, in fact.
Thank you. No, I also agree on that point. And then, okay, we are now at the end. I would like a final comment. And we started with you, Michelle, and then Natalia. I would like now to ask Natalia to have a suggestion, and then you to have your final comment to the huge group of people who are today with us, because the problem of the management of myoma and the management of adverse uterine bleeding are something which is still very present and makes problems in the general practice. Then Natalia, you, and then we will finish with Michel.
I would like again and again to thank you, dear Professor Genazzani, dear Andrea, for the honor of this kind invitation, and especially to speak in a company with so experienced and well-known professor as Michel. Thank you again. And for the doctors, the main idea is that it is possible nowadays to make a conservative treatment, uterine preserving treatment for women. And in our survey, we had a very interesting results that even women who said we don't want any fertility anymore, after achieving a healthy uterus, changed their plans and became mothers. So we have always to remember that the plan of a woman can be changed, but you will not be able to get back your uterus if you remove it as a first step. So it is my first idea and maybe main idea.
Yes, I thank you also because, you know, being a gynecologist deeply involved in general practice in all days, the maintenance of the uterus in the women is something which is rewarding for herself, for her femininity. But sometimes the uterus is bringing problems, and the problems are bigger than what the single patient can manage, also according to their condition. And but thank you very much for the nice words. And I would like to have the final observation. You know, you are both of you. You are two masters in different countries and positions and situations who face the daily problems of your friends gynecologists. And then Michel, I would like to have your comment about these points.
Okay. Thank you, Andrea, for this very nice webinar. In fact, I would say firstly that my daily practice, if I have a patient with abnormal uterine bleeding, always the first step is the medical treatment. I never operate a patient without trying a medical treatment. In the past, it was only progestin continuously. Nowadays, it will be more antagonist with ADVAC therapy, and according to the results, I will follow the patient. And I will propose surgery only in cases of failure of medical treatments, and the type of the surgery will depend on the age of the patient, the size of the myoma, and the localization. As much as possible, minimal invasive surgery, it means hysteroscopic surgery, laparoscopic myomectomy according to the age, of course, because
Yes.
at the age of 47 years, I will not perform a myomectomy, I will perform an hysterectomy by laparoscopy. And in fact, conservative or non-conservative treatment will depend to the discussion of the patient, but minimal invasive surgery as much as possible. And I would like to thank you, Andrea, for this nice webinar with interactive discussion and a very interesting discussion.
Thank you very much. I thank all of you. I thank all of you. We are at the end. We are still have nearly 150 participants with us. I thank all of you. It was a very important session, very well done. I thank Natalia and Michel for the supportive help for the European Society of Gynecology. Now I invite all of you to join us also in the next. The next webinar organized by our society is dedicated to menopause vasomotor symptoms. It will be the 28th of May 2024, always at 3 o'clock Central European Time, and we will have two masters, Tommaso Simoncini from Pisa University and Herman De Piper. You will see different strategy, different approach, a common vision how to face vasomotor symptom for women health. I am sure you will enjoy. And today, thank you again, Michel. Thank you, Natalia. It was a fantastic, practical, and stimulating webinar. I thank you for your time that you dedicated to us. And I remind to all of you that now we are planning, it will be announced very soon, our next Congress, which will be here in 2025 in March in the fantastic city of Riga. You will enjoy that one. The news will appear very soon. Thank you very much for being with us.